Hello everyone, and welcome to the second of Arthritis and Osteoporosis Victoria's 2016 Musculoskeletal Health webinar series. My name is Jen Nolan, and due to funding from the Victorian Government, we are delighted to be providing this webinar at no cost to Victorian primary and community health professionals. I would also like to extend a warm welcome to health professionals who are tuning in from other states of Australia. Today's webinar will focus on the management of people with osteoporosis. Our presenter for today is Dr Christopher Yates. Chris graduated from medicine at the University of Melbourne in 2002 and completed his specialist training in diabetes and endocrinology at the Royal Melbourne Hospital and Western Hospital. He completed a PhD at the University of Melbourne and then undertook a postdoctoral fellowship at the University of Oxford studying endocrine tumours. He is now employed as an endocrinologist at the Royal Melbourne Hospital and Western Hospital and maintains his involvement in clinical research in the fields of diabetes, pituitary disease and osteoporosis at the University of Melbourne. He is actively involved in teaching medical students and specialists in training. Without further ado, I'll hand proceedings over to Chris. Thanks very much, Chris.
No problem. Thanks, Jen, and thanks for participating. So feel free to ask questions. I'll answer them at the end, but we'll get started on the presentation. So osteoporosis is a major problem that we face today, and the presentation today will go over the following. We'll review the current epidemiology. We'll look at fracture risk calculators and how they can help you in managing your patients. Look at recent calcium and vitamin D controversies, atypical femoral fractures and the rare side effect of osteonecrosis of the jaw, bone turnover markers, and the evidence for the different treatment options for osteoporosis. We'll also then look at what guidelines we can give you for the treatment of osteoporosis in patients. I understand that there's a range of different healthcare professionals, and hopefully you all find this helpful. So this image really does show you the difference between normal cortical bone and trabecular bone on the left, and then trabecular bone in an older individual with osteoporosis on the right. And you can see thinning out of the trabecular bone, and the matrix does become a lot less complex, and that places patients at a risk of fragility fracture. So osteoporosis is a triad really of low bone mass, microarchitectural deterioration, and a remodeling imbalance that favors resorption over bone formation. And the consequence is fracture risk, and the fractures that we see a lot with osteoporosis include fractures of the spine, hip, wrist, humerus, and clavicle, but we also do see increased fracture rates at any site. As an example of a Colles fracture, which is a typical fracture that we see in our elderly patients with osteoporosis. The burden of osteoporosis on society is significant. In patients over 60 years, there's a risk of osteoporotic fracture in 56% of women and 29% of men. In 1996, about 15,000 patients in Australia fractured their hip. This was forecasted in the late 2000s to increase to 21,000 by 2010 and up to 34,000 by 2026. Additionally, fractures of the spine affect 5% of patients between 50 and 54, and up to 50% of patients over 80 years of age. And often these spine fractures don't come to clinical care, so they're often patients feel back pain but don't seek GP or hospital care, and the fractures are incidentally found in imaging later on. The consequences of osteoporotic fractures are pain, loss of independence, and this is particularly prominent after hip fracture, and 50% of women post-hip fracture need to transition from independent living to some supported living arrangements. There's also a significant reduced quality of life. Mortality is also increased after all osteoporotic fractures, but particularly after hip fracture, with quite a striking increased mortality of 10 to 20% in the first year following a fracture of the hip. Now, the fracture of the hip may be a marker of other illnesses as well as osteoporosis, but certainly it does appear that hip fracture and osteoporosis treatment may prevent some of this mortality and certainly morbidity. On the right of that slide, you can see a classic example of a vertebral crush fracture, which I've mentioned sometimes doesn't come to clinical attention and just gradually progresses over time. I'll just escape out of that. So the cost of osteoporotic fractures is about $1.9 billion in each year, which is a significant economic burden. Now, fracture risk is not all attributable to the bone density, though we do measure the bone density as a surrogate marker for whether patients have osteoporosis. In fact, bone density is just one factor that contributes to fracture risk. You also have how well the bone is mineralized, what the patient or person's falls risk is, the size and geometry of the bones, with larger bones naturally being structurally stronger, the microarchitecture that I showed you in that high-resolution CT earlier, and any damage to that structure of the trabecular bone, and bone turnover. We can now assess fracture risk using a combination of risk factors, and this is from large epidemiological studies looking at fracture incidence. Now, the FRAX calculator is the most commonly used and is approved by the WHO. And this actually has calculation tools for fracture risk in many different populations. You can see here the American flag, meaning that the calculation tool selected here was for a US population, but you could equivalently choose an Australian population or a British population. You can see that this fracture risk calculator requires you to enter the age, sex, weight, height, and risk factors for osteoporosis. Once you've entered that, then you can put in the femoral neck bone density T-score and calculate the fracture risk over 10 years at the hip or alternatively at any other site. And this is really useful in deciding whether to treat patients and also in patients understanding whether or not there's a good reason to treat. If the fracture risk is actually quite low, then it may be reasonable to defer treatment. However, with escalating fracture risk, the decision to treat should be more strongly encouraged. We also, in the UK, with the FRAX tool, they've actually then taken it a step further and done cost-benefit analysis, whereby if your 10-year fracture risk falls into the green zone, then it's not cost-effective to treat the osteoporosis. However, if it falls into the red zone, then it is cost-effective to treat the osteoporosis. Now, this isn't available for an Australian population, but it is interesting from a population-level health management point of view that you can do these sorts of cost-benefit analyses in terms of treatment. There are other fracture risk calculators, such as an Australian calculator called the Garvin nomogram, where you similarly put in patient's age, previous fracture history, number of falls to work out a 5 and 10-year fracture risk in men and women. And this is also well validated. This comes from a large study in Dubbo. The diagnosis of osteoporosis is first a clinical diagnosis. If the patient has a fragility fracture, which is defined as a fracture occurring due to a force that's equivalent or less than a fall from standing height, then that's defined as a low trauma fracture and an osteoporotic fracture. That gives you a major clue to whether the patient will have a low bone density, but the bone density machine as seen here will tell you a little bit more detail. So the World Health Organization defined a bone density of less than or equal to 2 standard deviations below the mean population as being defining osteoporosis. So if the mean population would have a standard deviation of 0, if it's 2.5 standard deviations below that, then that by definition will class as osteoporosis. And we talk about T-scores, and that's what that means. So the Geelong osteoporosis study showed that by age 79, about 87% of Australian women would have osteoporosis by this definition. And as you will know, there is a relentless decline in bone density after you've reached peak bone density in your 20s and 30s. So if you live long enough, effectively your bone density will eventually reach these cutoffs, but some people start from much lower bone density and will progress more quickly to develop osteoporosis. The bone density sites that we consider are the lumbar spine, the total hip, and the neck of femur. Other sites in the hip are measured, but these are less commonly used to define whether or not osteoporosis is present. The total hip bone density is probably the most reliable and the least variable of those measures. The neck of femur is probably the most variable, and there's certain positional issues that can happen when you're doing a bone density test that can limit the accuracy of a neck of femur bone density measurement. Bone density scans are reimbursed for individuals in Australia over the age of 70, those that have had a minimal trauma fracture, those who've had a low bone density in the past more than 12 months ago, and those with therapies or conditions that predispose to osteoporosis, such as prolonged glucocorticoid therapy, over-replacement with thyroid hormone, rheumatoid arthritis, hyperparathyroidism, hyperthyroidism, chronic kidney disease, chronic liver disease, or malabsorption conditions such as celiac disease. Additionally, if men are hypergonadal with low testosterone, or if women have had premature menopause before the age of 45, then those patients can have a bone density subsidized. We can also do a 12-monthly monitoring if there's of your bone density if we've commenced osteoporosis treatment and then changed therapy, or in the setting of glucocorticoid therapy. Otherwise, we generally would only do the bone density scans every 2 years, and that is usually sufficient to detect issues of changing bone density. There are some risk factors for osteoporosis that don't qualify for the Medicare reimbursed DXA scans, and these patients would be forced to pay out of pocket for these scans. And they include a family history of osteoporosis, calcium deficient diet, vitamin D deficiency, low physical activity, low weight, smoking, and alcohol excess. Generally with osteoporosis, the first thing to do is to look for and to treat secondary causes of osteoporosis. The College of General Practitioners has these guidelines for the assessment of secondary causes of osteoporosis. We check a serum calcium level because if patients have an overactive parathyroid gland, that can raise their serum calcium and leach calcium out of the bones, rendering their bones thinner and the calcium levels in the blood higher, and treatment of that primary hyperparathyroidism will certainly make a big difference to their osteoporosis. We also check for a vitamin 25-hydroxyvitamin D level, and a level less than 50 is considered insufficient, and we would encourage patients to replace it at least up to 70 nanomoles per litre in the setting of osteoporosis. Vitamin D is critically important for the absorption of dietary calcium or of calcium supplements. We check liver function tests, and particularly we're interested in the alkaline phosphatase in the liver function test, which actually can represent bone formation. As well as being a liver marker, it's a bone marker of bone formation. The kidney function and inflammatory markers tell you about the risk of renal osteodystrophy or renal bone disease and inflammatory disease respectively. And a full blood count and serum protein electrophoresis can tell you about rare bone marrow problems that can be associated with osteoporosis. Additionally, you can check a morning testosterone level in a male if you suspect hypogonadism, and a serum TSH will tell you if the patient has an overactive thyroid, and that's placing them at risk of osteoporosis. Generally then, we want patients to try and maintain a healthy weight. If they're smoking, to cease this, to moderate alcohol consumption, as this is also a risk factor for osteoporosis, and provide education and support about dietary measures to improve calcium, vitamin D. Regular high-intensity weight-bearing exercise certainly does load the bones, and a loaded bone will stay stronger than a bone that's not used with its intended purpose. There have been several issues about calcium, and you'll note that I said we try and optimize dietary calcium first, and that comes from these sorts of data. In the past, previously, anyone with osteoporosis has been started on a caltrate or a citracal tablet in addition to their osteoporosis treatment and vitamin D. But we've stopped doing this routinely. If patients can have 1,200 milligrams of dietary calcium, that is ideal. The reasons are these. In studies with calcium supplementation, it's been shown to reduce bone resorption, reduce bone loss, and with vitamin D to reduce fracture risk. But taking a calcium supplement can sometimes lead to a spike in your blood calcium. And a 5-year randomized control trial of patients taking 1 gram of calcium citrate or citracal in 1,500 postmenopausal women showed an increased risk of myocardial infarction and a non-significant increased risk of stroke in these patients. Now, it's important to realize that these postmenopausal women were already consuming 860 milligrams per day of dietary calcium in the form of milk, cheese, yogurt typically. And then on top of that, they added 1 gram of calcium citrate, so they had about 1,860 milligrams of calcium each day. And you'll note what they recommended was 1,200 to 1,300 milligrams of calcium intake per day. So these patients were effectively overdoing it with the calcium. And in those patients, there was an increased risk for myocardial infarction. And so we certainly don't want patients to have 1,800 milligrams of calcium a day. Calcium is certainly an element that you can have too little of and too much of. And aiming for that sweet spot of 1,200 to 1,300 milligrams a day is a good idea. The risk of myocardial infarctions has been borne out again by the same group, a New Zealand group by Ian Reid, that showed when it did a meta-analysis of 11 calcium studies that there was still an increased risk of myocardial infarction. And again, in these studies, patients were generally taking more than 1,200 to 1,300 milligrams of calcium per day. So we recommend calcium-rich dairy, and the reason we recommend dairy is it's the strongest source of calcium intake. You can get calcium-enriched soy products, which is a good substitute for those that are lactose intolerant. But certainly ingesting calcium through food, it means that you're having it in combination with some protein and some fat, and that slows down the absorption of calcium, leading to reduced spikes in the blood calcium. And it seems to be a more physiological way to take calcium. And we use low solubility calcium, such as a caltrate, in combination with meals if we have a diet that is insufficient in calcium. So if the patient simply can't have enough calcium in their diet due to intolerance of milk, etc., then we would use a caltrate with dinner, and that could be potentially with an evening meal after they've assessed how much calcium they've had during the rest of the day. So these are the different sources of calcium. Not many people have tins of sardines with edible bones these days, so it generally does come down to dairy foods. We don't recommend you get all of your calcium from chocolate. Vitamin D. Vitamin D is recommended in patients with osteoporosis to achieve a level that is greater than approximately 70 nanomoles per litre. And we know that taking vitamin D at doses of around 700 to 800 international units per day has been associated with reduced falls and fractures. There have been studies from Geelong that showed that trying to simplify treatment and just give it once every year at 500,000 international units didn't work. In fact, these patients had an increased risk of falls and fractures. So it's best to take a smaller amount of vitamin D more regularly than to take a large dose once a year. The amount of sunlight to get 500,000 international units in one big go would be certainly a lot. So the general advice for sun exposure to try and get vitamin D synthesis through your skin is about exposure of about 15% of the body, which is your hands, face and arms, for about 6 to 8 minutes, 4 to 6 times per week. And we generally like the low UV times to avoid the risk of skin cancer before 10 a.m. and after 2 p.m. And if you take a supplement, it's generally worth taking more than 800 international units. So Osteon 1000 or other brands generally come in doses of one tablet, meaning of 1000 international units per tablet. With regard to the specific treatments for osteoporosis, we have quite a few available now, which is very fortunate. This includes bisphosphonates, denosumab, selective estrogen receptor modulators, HRT, anabolic agents or bone-building agents like teriparatide, and agents with mixed bone formation and anti-resorptive effects like strontium ranelate, which certainly has not been prescribed much recently due to black box warnings, and we'll go through that in a moment. With the bisphosphonates, these have been around for the longest period of time. These agents are rapidly taken up into bone and have a long half-life in bone, and so its action persists long after you've stopped taking it. They interfere with the osteoclast function, and osteoclasts are responsible for bone resorption. These agents induce osteoclast apoptosis or death. The agents that we have available in Australia include alendronate, which is once a week, risedronate, which is once a week or once a month, and zoledronic acid, which is an annual infusion. Patients qualify for these on the PBS, and if they're over 70 with a T-score of worse than minus 2.5 actually, and if they've got established osteoporosis. They also qualify for these if they've had greater than 3 months of treatment with 7.5 milligrams of prednisolone per day, as that's an osteoporosis risk factor. And if their bone density in that context is less than minus 1.5. The bisphosphonates are well tolerated generally. The main side effect that they have is gastroesophageal reflux disease, and patients who've got problematic symptoms of ulcers, gastroesophageal reflux, perforation, strictures may not be the best candidate for these agents. The intravenous zoledronic acid is also associated with a flu-like reaction which occurs for a few days after a dose, and this includes fever, sometimes myalgia, headaches, and arthralgia. And if patients are warned about it, it's generally less concerning, and they usually treat with adequate hydration and paracetamol regularly for those few days, and then it subsides. Okay, there is a very subtle increase in atrial fibrillation in some of the studies, and an increase in the creatinine, which is transient in some of the studies. The advantage of the intravenous formulation is a compliance advantage, and we know that in studies have shown that the oral bisphosphonates may only be taken in about 58% of occasions intended at a period of 12 months following prescription. Osteonecrosis of the jaw has had a lot of media play, and certainly these sorts of pictures on the web are quite frightening. Patients come to my clinic quite concerned about this potential side effect. Osteonecrosis of the jaw is where generally you have an ulcer over an area of exposed mandible, and it's usually following a dental extraction or significant dental intervention deep into the mandible. The most high-risk patients are patients that have bisphosphonates administered at higher doses more regularly for cancer to stabilize the bony disease due to their cancer. And these doses are about 12 times more than what we give for osteoporosis, and they're quite frequently dosed, and these patients have other things going on. In an osteoporosis population, these side effects are quite rare, probably in the order of around 1 in 10,000 patient years. Atypical femoral fractures also get a lot of media play, and these fractures have been noted to occur in patients who've sustained who have been on bisphosphonates for about 10 years. And you can see this fracture here is a transverse fracture across the shaft of the hip, and this is not a typical area where the femur would fracture. This is a patient I looked after at the Western Hospital several years ago who sustained a similar fracture, transverse fracture across his hip, and this patient actually also had a prominent jaw and was very short in his stature, had an open anterior fontanelle despite being in his 40s. And this patient had a condition which has also been a condition that Toulouse-Lautrec, the famous painter, had, and this is called pycnodysostoses. And this condition is a condition that affects the osteoclast. And you'll note with the bisphosphonates, we're inhibiting the osteoclast. So with these patients with pycnodysostoses, the osteoclasts don't work properly, and in the end, they can be subject to, they can have an increased bone density, but the bones can be more brittle, and there can be a risk of getting these transverse fractures across the femur. This is some of Toulouse-Lautrec's artwork. Basically, there are theoretical reasons why bisphosphonates may be associated with these atypical femoral fractures with prolonged use due to prolonged inhibition of the osteoclast function. Although the incidence of these rare atypical femoral fractures is extremely rare, whereas the incidence of typical osteoporosis fractures, which are known to be prevented by these agents, are very common. So we generally do not avoid prescribing osteoporosis medications for fear of atypical femoral fractures. However, we do avoid very prolonged therapy of 10 years or more with these agents, and certainly if patients come to us after prolonged therapy with some femur pain or thigh pain, we'll certainly think about x-raying the femurs, looking for any stress fractures or risk there of atypical femoral fractures. There is a new class of drugs coming that actually utilizes the condition that thought about the condition of pycnodysostoses to design a new anti-resorptive agent using that sort of knowledge, and those are in trials still. They're not available yet on the PBS. One of them is called Denosumab, and it's certainly associated with increased bone density and reduced fractures. Strontium ranelate is a mixed anti-resorptive and anabolic agent, which has got a black box warning now, but contraindicated in any patient with ischemic heart disease, peripheral vascular disease, DVT, pulmonary embolus, or those that are immobilized due to its risk of heart disease and of increasing risk of heart disease and thrombosis. This agent was used up till about 2 or 3 years ago more commonly. Now it's really a second-line agent for patients with terrible osteoporosis with no other treatment options. Denosumab is used much more frequently now. It's a monoclonal antibody to rank ligand that's been around for 6 or 7 years, and there are data showing its effect over that period of time. Rank ligand is a ligand that binds to a protein called rank on osteoclasts, and when it binds, that stimulates the osteoclasts. So if we have a monoclonal antibody to rank ligand, that mops up the rank and prevents it binding to osteoclasts, and that prevents the osteoclasts from being activated. And as a consequence, there is reduced bone resorption, and patients improve their bone density, and they've certainly shown reduced fracture risk with these agents. It's very convenient to take. It's once every 6 months, which is great, and it can be administered in the clinic at the GP surgery, which is very convenient. It must be taken every 6 months, and if you forget to take it every 6 months, it's quite different to bisphosphonates, where there's a lingering effect of the drug. These agents simply stop working, and the bones resort back to their natural state in the osteoporotic state. So these agents are more agents that you continue longer term, and we haven't yet reached a point where we'd say after this amount of time you must stop these agents. It's generally ongoing therapy unless there's been a reason to change. With Denosumab, it's been studied. Its major study was involving about 8,000 women treated for 3 years, and this is the initial studies that got it on the PBS, and it showed a decrease in vertebral fractures in around of 2.3% versus placebo at 7.2%, and decreased hip fractures with a relative risk of just 0.4, and decreased non-vertebral fractures with a relative risk of 0.2. It does improve the bone mineral density more potently than alendronate. It is associated with some side effects like musculoskeletal aches and pains for a few days after taking it, with hypercholesterolemia, and sometimes with bladder infections. Rarer infections such as skin infections, and there's a few isolated reports of endocarditis and other infections that you should be aware of, but I haven't seen in reality in clinical practice. Because these are also osteoclast inhibitors and affect bone resorption. There's also a risk of osteonecrosis of the jaw, and also we have seen atypical femoral fractures with this agent. Recombinant parathyroid hormone, or teriparatide, is our only anabolic agent available. That's the only bone-building agent available on the PBS. It costs about $11,000 per annum, and this acts on the osteoblasts that make bone rather than inhibiting the osteoclasts that take away bone. By giving this recombinant PTH as an injection each day, the osteoblasts are stimulated to put down more bone, and this certainly increases the bone density prominently. It's reserved on the PBS due to its expense to those who have severe osteoporosis with a T-score worse than -3, who've had 2 or more minimal trauma fractures, and at least one of those fractures must have occurred whilst being on an anti-resorptive such as a bisphosphonate or Prolia for at least 12 months continuously. This agent's associated with some dizziness, cramps, nausea, and local injection site reactions, and some patients can get mild transient hypercalcemia due to the PTH action, so I do generally check calcium levels in these patients. I don't want you to give this agent to patients who've had a history of bone cancers, as high doses given to rats in the initial studies showed an increased risk of osteogenic sarcoma, so we haven't seen that in humans. But we do note that there have been case reports of osteosarcomas in patients with hyperparathyroidism where there's prolonged PTH exposure. So there is a theoretical risk that this could happen in people. So we don't also give these agents due to that risk of osteosarcoma to patients with Paget's disease, prior skeletal radiation, anyone with bony metastases, prior skeletal malignancies, or metabolic bone disease other than osteoporosis. We certainly wouldn't give it to those with hypercalcemia. There are other anabolic agents in the pipeline. There are conditions that these agents have been based on. So Van Boeckham's disease is a disease of heavy, high-density bones, and these patients will sink if you put them in a swimming pool with Van Boeckham's disease. And there's the problem here is a sclerostin problem, and in the pharmaceutical companies have been quite smart thinking about this pathway to think how can we use this pathway to our advantage to build stronger bones. Sclerostin inhibits the normal bone strengthening pathways, and so the pharmaceutical companies have created this thing called an anti-sclerostin antibody, and that will therefore enable the bone formation pathways leading to stronger bones. Now, bone turnover markers are a good way of assessing how well your treatments are working and how the bone's working. So bone turnover markers include a beta-CTX, which is a marker of bone resorption, alkaline phosphatase, and a P1MP, which are markers of bone formation. And here you can start to assess how much resorption versus formation there are, and there are normal ranges for postmenopausal women, normal and premenopausal women, and for men. And so usually if we start a bisphosphonate or Prolia, we'll see a potent fall in the bone turnover markers, and that shows that the patients are taking these agents. So it's a good way to monitor that they're taking it. Also, whether the agent's actually working. If they're on these therapies and there's no reduction, then you certainly need to think about why. And it's something that is monitored more and more. Bone turnover markers need to be measured in the fasting state first thing in the morning, as they are affected by food and diurnal variation. Here you can start to see the evidence behind the commonly used osteoporosis medications. There's no head-to-head studies with this, so this is just taking Cochrane reviews for each and the Sentinel studies for zoledronic acid to give you the relative numbers you need to treat to prevent fractures with these osteoporosis agents. So strontium ranolate we might gloss over because we're not really using that very much at the moment. Alendronate, the Cochrane review of 12,000 patients showed that you need to treat 17 patients to prevent a vertebral fracture with alendronate, and that you have a vertebral fracture risk reduction of 0.55 with that agent, and for non-vertebral fractures you need to treat about 50 patients to prevent one. And for hip fractures, you need to treat about 100 osteoporotic patients with alendronate to prevent one hip fracture, and you'll certainly see an increase in the bone density. Risedronate is quite similar in numbers as alendronate, and with zoledronic acid are slightly different in that the number needed to treat to prevent a vertebral fracture is just 13, and the number to treat to prevent a non-vertebral fracture is 37, and to prevent a hip fracture is 91. You can see a slightly more potent increase in the bone density versus risedronate, but similar to alendronate, and probably those differences are all not significant. With recombinant PTH, the number needed to treat to prevent a vertebral fracture is just 10, to prevent a non-vertebral fracture is 33, and you'll see potent improvements in the bone density with these agents. Compared to alendronate, there has been a head-to-head study with teriparatide, and teriparatide certainly improves the non-vertebral fracture effects versus alendronate, and certainly strengthens the bones more than alendronate. So in summary, with postmenopausal osteoporosis, bisphosphonates and denosumab have excellent evidence for fracture prevention. Dental extractions and healing should occur before these agents are commenced, just to minimize the chance of osteonecrosis of the jaw, which certainly is more likely if you have an open wound deep down into the mandible. If you've got a patient who's unable to sit up for 30 minutes after taking their bisphosphonate, or has bad gastroesophageal reflux disease or peptic ulcer disease or esophageal motility problems, oral bisphosphonates are probably best to avoid. We generally avoid strontium at the moment unless there's absolutely no other agent that these patients can take. If there's compliance issues, you might be better off on annual zoledronic acid infusion or 6-monthly Prolia, or perhaps monthly risedronate formulation. And I think after 5 to 10 years, you should consider whether or not it's time to have a holiday from the bisphosphonate. The time would be to consider that would be if the patient hasn't had a fracture, if their bone density certainly improved out of the osteoporosis range, and that they're relatively low risk of fracture using something like the FRAX risk calculator. You should consider recombinant PTH in patients with severe osteoporosis or those that have had a poor response to other agents. And I'll probably leave it there, Jen. So I'll open it up for questions now.
Okay, we have got, thanks very much, Chris. It was a very comprehensive presentation. We have got a couple of questions that have come through, and we've got a very limited time for questions today, given we have to finish right on 1:15. So I'm sure you'd be happy to answer a couple of questions offline if we don't actually get through to them.
That'd be fine,
in the remaining time. So there was a question that came through with regards to when you talk about the prolonged duration and the use of steroids, exactly what is that sort of time period, and what is the dose of steroids that you would be thinking of in that case?
So the normal endogenous production of steroids would be about equivalent of 7.5 milligrams of prednisolone a day. So that's how much a normal person with functioning adrenal glands would normally make in terms of steroid per day. So when you start giving steroids as medicines and you're exceeding 7.5 milligrams a day, or taking equivalent of 7.5 milligrams a day of a steroid, then you're starting to give extra steroids than would normally be there, and that's what we see is associated with osteoporosis development. So that the different steroids have different potencies. So we'd say prednisolone 7.5 milligrams a day or higher for 3 months, or the equivalent dose of the other steroids, and your doctor can help to tell you whether or not you're on an equivalent dose of 7.5 milligrams of prednisolone.
When you're talking about various risk factors, someone's just queried, would permanent spinal injury also be a potential risk factor for osteoporosis?
Yes, it would be, particularly if the patient or person has been immobilized. I think if you're unable to bear load on your skeleton is very efficient in reducing its bone density to the needed level. So basically a non-weight bearing state or reduced weight bearing will quickly result in thinning of the skeleton. And so we see that very prominently in astronauts that come down after some time in space where there's zero gravity and there's no weight bearing. They'll have quite thinned bones, which takes some time to improve. So probably through that mechanism, that's the main mechanism where spinal disease could lead to osteoporosis.
if someone has normal bone mineral density, but they've had a low trauma fracture, are they eligible to be commenced on bisphosphonates on the PBS?
Yeah, so if you've got a clinical diagnosis of osteoporosis, you can be treated. So a clinical diagnosis of osteoporosis is a low trauma fracture, and so the bone density is trumped by the clinical diagnosis of osteoporosis. So the problem we have in the PBS is if you're younger than 70 and you haven't had a fracture, but you've got thinning bones, osteopenic bones, then it's not going to cover you on the PBS. But certainly if you've had a fracture due to low trauma and it's thought to be an osteoporotic fracture, then you certainly qualify for the treatment.
And do patients...
Sorry, another added comment. It's not the end of the world if the PBS doesn't cover you, because you can actually get these agents as a private prescription with evidence to back using it. Not that it's approved, but it's just not subsidized. So, and agents like alendronate and risedronate aren't particularly expensive these days, and if you shop around, you can get them at quite an affordable price.
Do patients get a better outcome of lowering their fracture risk with a multimodal intervention such as weight-bearing exercise, calcium supplements, clinical treatment, particularly among older adults? Yeah,
we would. I would never recommend just take a tablet and forget about the rest. I mean, it's always multimodal. We would always think about optimizing dietary calcium, get them exercising, get their vitamin D up to scratch, whether that's just through lifestyle or through supplementation, and then thinking about using an anti-resorptive agent if needed. And that's also combined with the other things that I mentioned, like moderating your alcohol, stopping smoking if you're smoking, and treating any secondary cause of osteoporosis that you might uncover in your testing.
Now, you may have covered this, Chris, already. Is one bisphosphonate better than another?
So the bisphosphonates have all got good data, as I showed you in that slide. I think from that slide you sort of appreciate that zoledronic acid's a more potent bisphosphonate. It increases the bone density more. But it probably has a slightly increased side effect profile too. So there's a time and place for each is what I think, and probably risedronate and alendronate are fairly interchangeable. They have fairly similar data. The heartburn scenario, peptic ulcer disease scenario really does discourage you from using the oral bisphosphonates. And then you might think about denosumab or zoledronic acid in those patients. In patients that have, more mild to moderate disease, you might try an oral bisphosphonate, and if it's not winning, you could go to a more potent agent like denosumab or like zoledronic acid. So I think that's probably how I think about it at the moment.
And should a GP monitor bone turnover markers regarding bone health, particularly to see the compliance or the sort of efficacy, I guess, of the bisphosphonates?
I wouldn't discourage it. I think that it probably doesn't need to be done very often. It does need to be done in fasting in the morning, otherwise you're just going to get misleading results. So bone turnover markers, beta-CTX, P1NP, alkaline phosphatase can be mainly a marker of compliance or efficacy of the medicine. If it's not falling and you're on the agent, either the patient may not be taking it or they're taking it with poor technique, which sometimes happens. So if you take it too close to food or with a calcium tablet, the bisphosphonate will be bound up with the calcium in the tablet or in the food and then never get to the bones. Those sorts of scenarios do happen. So technique's important. Bone turnover markers might give you some insights into that.
Sorry, Jen, you seem to have your phone muted.
Exercise recommendations for osteoporosis. Any particular guidelines you'd recommend, Chris?
So, I guess one thing that separates this from normal healthy lifestyle guidelines of 5 days a week, 30 minutes of weight-bearing exercise would be that if you've got severe osteoporosis, you don't really want to be lifting, very heavy things above your head for risk of vertebral fractures. So you got to take weight-bearing exercise meaning that you're carrying your own body weight, but you don't certainly need to be carrying heavy arm weights or weights on your back to try and stimulate your bones to be strong. So I discourage people from lifting really heavy weights, particularly above their head, and weight-bearing exercise, I just mean carrying your own body weight generally, and walking is probably a really good form of exercise to keep your bones healthy. 5 days a week, 30 minutes minimum.
Okay, listen, on that note, we will stop now, given Chris has got a very tight schedule today. Thank you so much, Chris, for a very comprehensive presentation. Thanks, everyone, for joining us today. And could I please ask that you respond to the questions in our exit survey, which will appear on your screen soon after the webinar finishes. So on that note, thanks to everyone for joining us today.
Thanks
Good
for
afternoon.
participating. Thank you.
Thanks,
Jack.
Chris.
Thanks, Jen.